I'd now like to introduce Dr. Deanna Windham.
Hello, everybody. I'm Dr. Windham. Can everyone hear me okay? My voice is kind of small. Okay, good. So, how do I get this on the... Linda, do you know how to make this into a actual presentation? Oh, wait. Down at the bottom. Just got it, thank you. Okay. So, my approach is a little bit different. I'm going to be talking to you from the point of view of a clinician. It says, oh goodness. I'm sorry, give me just a minute here. Lindy, do you know how to do this? Well, oh, you guys can see it just fine. Okay. I can't. All right. I was trying to get to my notes. Does anybody know how that I can see the presenter notes? Unless you know how. No, that's not why you're there. Okay. Hope springs eternal, as they say. Okay, so I'm going to be speaking to you today from the point of view of a clinician. I'm a doctor. I use low-dose naltrexone myself, and I use it in my patients. I was a patient who suffered from autoimmune disease from the time of infancy, but nobody knew that in 1969, that autoimmune disease was even possible. So I was finally diagnosed with lupus at the age of 33. And low-dose naltrexone was part of the plan that helped me to heal and changed my life. And that's also when I started using it in my patients after I'd used it in myself, which was very early in my career. So many or most or all of you know the basic information of how low-dose naltrexone works, but I wanted to just bring it up quickly that as you're likely to know, low-dose naltrexone blocks opioid receptors at night while you're sleeping. The sweet spot, as they say, is supposed to be between 2 to 4 a.m., so taking low-dose naltrexone at night before bed is important if you can do it. It upregulates your body's ability to make and use endorphins, and endorphins control the immune system. So this is how I explain it to my patients, a simple process of how it works. And I often tell my patients, which I thought might help you as well, to talk to your patients and also to help you to understand what's going on. I like to think of my endorphins as kind of like a second grade teacher, and the immune and endocrine system, the cells in that system, as the second graders. So if you don't have enough endorphins, or if your teacher leaves the classroom, then your immune system and your endocrine system is likely to misbehave. So if you think of this as second graders, then your second graders are going to be roaming around the classroom in a chaotic way. And when the second grade teacher comes back in, she's able to redirect their rambunctious play and direct them towards appropriate tasks. And this is how I tell my patients that that endorphins do the same thing for your immune and endocrine system. So it directs your immune system as the correct mode of behavior and redirects the bad behavior of your immune system, if you will. It's overly simplistic, but it's a nice way to think about it and to talk about it. Okay. So the reason that I wanted to bring up why we're talking about allergies and autoimmune disease together, these seem like very disparate disease processes. But there are several things that link these two disease processes. One of them is something called heat shock proteins. And if you'll notice in the last sentence here, heat shock proteins are recognized as antigens in autoimmune disease and in allergies. And this, in this article, they actually go on to say that these two disease processes have very similar biomechanical processes going on at a cellular level. So that's how these two things are related. Also, if you look at the triggers for autoimmune disease and the triggers for allergies, you'll see that the triggers are very similar So in autoimmune disease and in allergies, the triggers, for clinicians, you already know this, for any non-clinicians, triggers are just what it sounds like, something that increases your propensity of developing a certain problem, a certain medical problem. And with these certain triggers, these are the things that cause your immune system to develop autoimmune disease or allergies, given the right situation. Always genetics at the bottom here is you have to have a genetic predisposition for something. But with that genetic predisposition, if you add that in to the environmental stimuli and hormonal and neuroendocrine problems that are all of these contributing factors, this is actually shown to be what causes what triggers or activates the autoimmune process. And according to this, I love this book. It was just published in 2012, and it's one of the immunology textbooks. If you're going to become an immunologist, this would be part of your required reading. And I love this because there's a lot of information in here that I thought wasn't widely accepted. So I was very pleased to read some of these things. But that's one of the reasons that I thought that this was so important. We know that these are the things that cause progression of the disease process. So when you have all of these triggers that we were just talking about, these triggers cause a cascade of things to happen in your body. One of the first thing that happens is that the hormonal HPA is the hypothalamus, pituitary, and adrenals. So this is your hormonal axis, and this activates or becomes dysfunctional. That causes the release of glucocorticoids, stimulates the sympathetic nervous system, which is the fight or flight nervous system. It's not something that you want chronically stimulated. These two things result in epinephrine and norepinephrine being released and mobilization of endogenous opioid peptides. A lot of the instances of a lot of the symptoms that people experience, a lot of the disease processes are caused by opioid interaction at a cellular level. So opioids used to be believed to only act in the brain. We know from research that starts back in the 1980s that opioids act in all the cells in your immune system, and they also act in the cells of your endocrine system. So opioid peptides have actions on all the cells of your body and an interaction with both the innate and specific immune responses. So innate is what you're born with, specific is what your body learns over your lifetime. And what happens when you have these chronic overactivation of the opioids, which is believed to be the cause of a lot of these inflammatory and autoimmune conditions? These opioids increase the inflammatory cytokines. I was really happy to see Dr. Smith talking about the cytokines down here so that you guys would know what I mean when I'm talking about the cytokines. So cytokines are signaling molecules. They're the ones that help the cells to talk to each other. The opioids disrupt the hormonal axis. It impairs and inhibits a person's immune system, stimulates tumor cell growth, and inhibits the ability of the body to function and increases vulnerability to infection. Research has actually shown that in mice that are born for that are given cancer or are given infectious agents, that if they're given opioids beforehand, they have higher rates of death. If they're given naltrexone before they're given the cancer or infectious agents, there are markedly increased rates of survival of those animals. So by suppressing the opioids, we know from research that it improves their ability to survive a serious infection and improves the animal's ability to fight off cancer cells. The importance of hormone imbalance is that we know that hormone imbalance is a part of the disease process. This has actually been shown in animal studies, human studies, different disease studies. We know that the hormonal imbalance is one of the first things that happens. That becomes important when I'm telling you about how low-dose naltrexone works. Your hormones, again, one of the things that they're doing, the way that they're having the effect on your immune system, is that your lymphocytes go to areas of disease, areas of injury, areas of inflammation in your body. And when your hormones are imbalanced, the balance between these Th2 and Th1 responses becomes dysfunctional. Th1, to put it simply, is the healing, repair, and regeneration portion of your immune system, and Th2, chronic overactivation of that, increases in inflammation, disease process. And so all of these receptor signalings, your cytokines, everything that your body's trying to balance, when your hormones are out of balance, they go into more of an inflammatory disease state without good hormone balance. Sorry about that one. It didn't look like that on my computer. So asthma and allergies, also the way that asthma and allergies are related to what we were just talking about with the hormonal imbalance and the cellular imbalance is that the Th2 inflammatory cytokines are actually considered at this point to be the primary underlying mechanism of asthma. Also, these inflammatory cytokines, this is the main thing that we're trying to treat when we're treating asthma with corticosteroids. We're decreasing these inflammatory cytokines in the body and also in the mucosa where the granulocyte colony stimulating factors causes mucosal damage and where IgE activation supports the symptoms of asthma and allergies. All of these things are activated by this Th2 inflammatory pathway, which is also activated by all of those triggers that we were talking about. I'm going to get to the low-dose naltrexone in just a minute and fit all this together for you. Another thing that causes your body to release too many opioids into your systems is actually foods, often gluten and casein. And these actually produce exogenous or outside of the body opioids. These opioids actually come from eating foods that you're sensitive to. A lot of patients that have primary bowel issues, like the ulcerative colitis, Crohn's, irritable bowel syndrome, inflammatory bowel disease, all of these things have, many of those patients are sensitive to gluten and casein, not necessarily have celiac disease or an allergy if you test it on traditional blood work. But if they're tested for IgG allergies or if they're tested for the IgA response on a stool study from the gut, we find that I would estimate in my patients about 70% of people have gluten and or casein sensitivity. Gluten comes from grains, casein from milk products. And that's consistent with what research shows as well. So all of these things that I've just been telling you about increase opioid production in your body. Your opioids, as I explained to you in an earlier slide, all the detrimental effects that it has on the body. This is not intended to be a exhaustive treatment evaluation of the traditional treatment plan for autoimmune disease or allergies, just to highlight some of the problems with the traditional treatment, with which, whether you're a patient or a physician, you know what those problems are. So they don't work very well. They're treating symptoms and not the disease process itself. So what we want to do is we want to address the cause of the disease and decrease the side effects from medications. Hence the reason that we're looking for other things to do that. It's been shown in the body that all of the organ systems, nervous, endocrine, and immune systems, connect, or rather communicate with one another. They communicate via the cytokines that I've been telling you about, the opioids, and the neuropeptides, which are active in all three systems, exhibit a number of immunomodulating properties. Again, I liked this and just wanted to show it to you so that you can see one of the neuropeptides is endorphins. So endorphins have an immunomodulatory effect. So remember that your opioid blockade increases your receptor sensitivity and production and increases endorphin production. So broadly speaking, we've been talking about all of the things that cause the autoimmune disease, or I've been trying to explain this to you the way that I tell my patients and the way that I tell other doctors when they call me to ask me what they should be doing if they're newly using low-dose naltrexone and why we recommend it for our patients. And broadly speaking, some of the effects of low-dose naltrexone that we know of, obviously we know about this one, decreases inflammatory cytokines throughout the entire body. The cytokine production the inflammatory cytokine production is decreased. It modulates your TMB lymphocytes. So this is your innate and your learned, if you will, immune system. These two immune systems get out of balance, and LDN actually helps to restore the healthy balance between these immune systems. This is one of the ways in which that does that. It helps to improve the activity of the Th1 or the healing system, and it also helps to balance the hormones. I'm going to talk, I have a great patient to tell you about later today in which we use this information with the hormone balance. On a cellular level, some of the most important things that are happening or that I talk to patients or their doctors about are the macrophage-induced tumor necrosis factor at the site of injury or disease that's causing cellular degradation and maintaining the autoimmune, or inflammatory response of disease. Neutrophils and eosinophils are also modulated. There are opioid receptor sites directly on these cells, and the endorphins, the increased endorphins from the low-dose naltrexone, helps these cells to behave more appropriately. So endorphins are decreasing your inflammatory cytokines, down-regulating the chronic inflammation, up-regulating healing, regrowth, and repair, and good for cancer, it stimulates natural killer cell activity. Everybody knows that a 4.5 milligram, I'm assuming, dosage of low-dose naltrexone is the best dose, or is the most common dose, although you can use down to 1.5 milligrams. You all know that. I didn't want to do an exhaustive talk about that, but some people I find in my practice are very sensitive to low-dose naltrexone. So how I deal with that in my patients is, as Dr. Bahari says, start at 1.5 milligrams and build up from that, and most people will tolerate that very well. But there's a subset of patients, often people who are very sensitive or people who are very sick at the end stages of diseases or very advanced diseases. I was actually one of these people who couldn't take low-dose naltrexone very well. So what we can do is we can start at very small dosages. You can start at 1.5, but if that doesn't work, don't be discouraged with your patients, because you can start at basically any dosage. So I will often start sensitive patients at 0.5 milligrams in capsule form and go up every 1 to 2 weeks until they've reached the therapeutic dosage. The way that I know somebody's reached, I always try to get somebody to 4.5 milligrams when I can. But often what I see in my patients is not just a side effect of difficulty sleeping sometimes, but they just don't feel good during the day. The most common thing I sometimes hear people say is that they just feel weird. And so if they tell me that if we're at 1.5 and they're doing great, and they go up to 2 and they just can't knock that feeling of not feeling well, then I usually decrease them down to 1.5, and in another few months we may try to go up again. So I try to get them to at least 1.5 milligrams. Especially in children, the liquid form, 1 milligram per milliliter, can be very helpful, or rather, oftentimes they can't take the pill forms, and it helps to dose up more slowly. So in very sensitive patients and in children, I like to start as low as 0.1 milligrams sometimes. Now, that's not usually required in children, and I think when we talk about patients today, I'm not sure I had a child that yes, I did, that I started that low. But most often I'm starting at 0.5. So this is when the children are very small, or if they're having high sensitivity or a very severe disease state. And in pediatrics, this is my estimate. Now, I've never seen this anywhere, but I've been using low-dose naltrexone for about 8 years now, and I find it to be fairly accurate that I do about 1 milligram of low-dose naltrexone per 20 pounds of body weight of the child. That's what I expect to get them to as far as their therapeutic dosage. And that seems to be working very well in my patients. Sometimes we'll go up by a half or a 1 milligram above that, but that tends to be about where they stay. And I did want you to know that, low-dose naltrexone is an opioid blocker, and we don't use low-dose naltrexone with opioids. But there's this interesting research that was published in 2000, and they showed that this ultra-low-dose naltrexone, that when it was given to people in concomitance with opioid drugs, actually improved the efficacy of the opioids and decreased dependence and tolerance to the drugs. Now, if I have a patient who's on long-acting opioids, the 12-hour opioids that they're taking every day at high dosage, I won't start them on low-dose naltrexone. But if I have a patient who's on as-needed opioids, and it's a case-by-case basis, but I do start some of my patients who are on opioids, I will start them on low-dose naltrexone, only we try to keep them at 1.5 instead of 4.5. And I have gone up to 3 milligrams in these patients. I ask them not to take the naltrexone at the same time as their opioids, that there should be at least 2 hours difference. And in these patients, I have had one that couldn't tolerate that, but the other patients in whom I've done this to, which has probably been, I would estimate about 25 patients that I've done this with, have done very well and have not noticed decreased sensitivity to the pain medicines, and have actually responded very well, and we've gotten all of them off of their opioids. So just to let you know that that is an option, and of course if you're going to think about that, you need to monitor closely for side effects. So if you're going to be talking to patients, the take-home message is to remember the short story of how it works. And I'll talk to you about different patients this afternoon, but if low-dose naltrexone pops into your head as something that you think might help a particular patient, I would encourage you to try it. I've tried it in some very interesting situations and found it to be beneficial in people who wouldn't be typical for low-dose naltrexone use. It has such varied positive effects and basically very little negative side effects, mostly just the ones that you already know about, sleep and maybe not feeling well during the day. And then, of course, start low and go slow if you're unsure. Hence the reason for the 0.1 milligram of the low-dose naltrexone. And I hope I didn't forget anything from my notes. I'm sorry I couldn't see them here.
Thank you very much.